In the previous section, we have discussed on the abnormal shapes of the RBC like dysmorphic RBC and RBC inclusions like various bodies like Pappenheimer bodies, Innes bodies and all. But in this current section, we are going to discuss on the RBC metabolism and the basic physiology of the RBC. Since this is concerned with a lot of physiology, I'm going to rush through these topics a bit faster. So what about the different RBC metabolism? So before going into the depths of the RBC metabolism, you have to understand one thing, that the mature RBC do not contain any organelles. They don't contain any organelles. You all know that the RBC does not contain nucleus, which means they are incapable of mitosis and replication. At the same time, they do not have Golgi apparatus, they do not have ribosomes, they do not have any RNAs, they do not have any DNAs, they do not have any endoplasmic reticulum. At the same time, they do not have any mitochondria as well. They do not have any mitochondria as well. What is the importance of this particular point, that they do not have any mitochondria? The most important feature of this particular point, that they do not have mitochondria, is the fact that they cannot produce energy through Krebs cycle or the TCA cycle. No TCA cycle is going on, which means they are going to produce less energy, but whatever energy they produce is going to be completely dependent on glycolysis. That is nothing but the Embden-Meyerhof pathway. I mean, evolutionary wise, there is a lot of questions why the RBC should extrude the nucleus and why they should be completely dependent on the Embden-Meyerhof pathway. That is because accelerating glycolysis within the RBC is going to increase the glycolytic intermediates, especially this glucose 6-phosphate and 1,3-BPG, which is then shunted to produce many other quintessential compounds within the RBC. So these are very important compounds in the RBC, which we'll discuss in some time, because production of NADPH through HMP shunt comes from this glucose 6-phosphate, which is a glycolytic intermediate, and this happens through glucose 6-phosphate dehydrogenase enzyme, which is 10%, almost 90% of the glucose is shunted to the routine glycolysis, and 10% can be shunted towards the hexose monophosphate shunt to produce NADPH, which is very important for protecting the RBC from oxidative stress, especially the RBC membrane from the oxidative stress and the hemoglobin from the oxidative stress. At the same time, you know, some of the 1,3-BPG is going to become something called 2,3-bisphosphoglycerate, and production of 2,3-bisphosphoglycerate is very important because this converts an oxyhemoglobin to a deoxyhemoglobin, because this 2,3-bisphosphoglycerate is going to bind with deoxyhemoglobin with a very high affinity, which means 2,3-BPG is going to cause oxygen release, which is very crucial and critical in the microcirculation at the cellular part, where they have to release the oxygen in the near the cellular side for the cellular respiration, so which is extremely important. Which means because of the oxygen release, this can also shift the ODC to the right, shift the oxygen dissociation curve, oxygen hemoglobin dissociation curve to the right, which just means an oxygen release. So 2,3-BPG is essential for oxygen release in the tissues by the hemoglobin. So how will you produce this 2,3-BPG is through the Rappaport-Lubring cycle. So the most important enzyme that is important for this conversion from 1,3-BPG to 2,3-BPG is called 2,3-BPG mutase. This mutase enzyme is the key for conversion of 1,3-BPG to 2,3-BPG. Now you can understand why evolutionary wise glycolysis is accelerated in the RBCs. That is because not only this just the glycolysis is accelerated because the nucleus is not there. Why the nucleus is lost evolutionary wise in the RBC is to accelerate these two pathways, which are very, very important, and they are forming intermediates, which is again important for producing this NADPH and 2,3-BPG. And what is the importance of NADPH? If you ask me what is the important role of NADPH in RBC metabolism, let us say in oxidant stress. For example, you have an oxidant. In that you have an example of a hydrogen peroxide. For example, you have an hydrogen peroxide oxidant which has to be reduced. So if we add this hydrogen ions, it will be reduced. Addition of hydrogen is what we call reduction. So this has to be reduced, otherwise this is going to generate free radical like oxygen free radical and OH free radical, because this is an oxidative compound. So to avoid this and to bypass this and to produce a non-oxidative compound like water or a neutral compound like water, you need hydrogen molecules. You need to reduce that oxidative products. So how can you reduce is through an important compound that is called glutathione, and it has to be in reduced state. means they have hydrogen. That is why we are calling it as reduce. Addition of hydrogen is reduction and addition of oxygen is called oxidation. So it is hydrogen added glutathione, that's why we called it as already a reduced form of glutathione, and this is going to produce this crucial hydrogen to this oxidative compounds, which is resulting in harmless water, and they are going to reduce this harmful oxidative compounds to harmless neutral compounds like water. And once they do that, they are going to form a oxidized glutathione, which means they don't have hydrogen at all. Obviously they are losing their hydrogen and they are forming an oxidized form of glutathione. But to maintain, because the next time when the oxidation stress starts, you need this reduced form of glutathione stored in the cell. So how will you maintain this reduced form of glutathione store? It has to be shifted back to its reduced form by addition of hydrogen to glutathione. So how will you add hydrogen to the glutathione? It is by NADPH principle. This NADPH is actually coming through glucose 6-phosphate dehydrogenase pathway in the form of HMP shunt, which is coming from glucose 6-phosphate, which means this is one of the glycolytic intermediates, and that is the one that is giving rise to this NADPH production, which is going to get converted to NADP, and that is how this H plus is shunted to the glutathione, producing a reduced glutathione. So which means this reduced glutathione stores, to maintain within the cell you need NADPH, and for NADPH you need G6PD, and for G6PD you need a glycolytic intermediate. Any problem in these might result in a lot of complications like hemolysis and anemia. For example, what will happen if you don't have a G6PD in your RBC? If you don't have a G6PD, glucose 6-phosphate enzyme in the RBC, your NADPH production will stop and it will decrease, which means you cannot produce reduced glutathione, which means your oxidant stress will increase. This oxidant stress will denature hemoglobin and they are going to damage the RBC membrane. Once they damage the RBC membrane, this all are going to result in intravascular hemolysis, and this denatured hemoglobin is the one that's going to produce something called Heinz bodies within the RBCs. This is the basic pathophysiology of G6PD deficiency, and this is what is crucial in understanding about all these processes, if you ask me. So the next thing, apart from after knowing this general events on RBC metabolism, it is crucial to understand about RBC structure. That is what I have given in the slide. This is what the membrane structure of the RBCs. So RBC membrane, if you ask me, there are two interactions in the RBC membrane. One is called the horizontal interaction and second one is the vertical interaction. Let me put all the horizontal interactions in black and let me put all the vertical interactions in red. So horizontal interaction, if you ask me what are horizontal interactions, this is made by peripheral proteins. And what you mean by vertical interaction, these vertical interactions are made by something called integral proteins. If you ask me what are peripheral proteins and integral proteins, very simple physiology. It's the first chapter in many physiology textbooks. These peripheral proteins are nothing but these are present outside the membrane, outside the cell membrane, which means not embedded within the cell membrane. These integral proteins are located within the membrane, which means they are embedded within the cell membrane. That is why we call them as integral proteins. When you ask about the types of peripheral proteins, if you see in RBC, your ankyrin is a peripheral protein, your spectrin is a peripheral protein, tropomyosin is a peripheral protein, actin is a peripheral protein, this band 4.2 is a peripheral protein, which is otherwise referred to as something called pallidin, and your band 4.1 is also a peripheral protein, which means if I want to shade them, ankyrin, spectrin, tropomyosin, actin, pallidin, 4.1, all these things are peripheral proteins which are located outside the cell membrane, which means it is not located within the cell membrane. That's why. If you ask me what are the integral proteins, I can tell two things. One is the band 3 protein group and second one is the glycophorin group. This is glycophorin ABC, that's a glycophorin group, and this band 3 protein, which is an anion transport protein. So these are the two proteins that form the integral component of the RBC membrane. That is the integral proteins which are embedded within the RBC. You can see, they are embedded within the RBC membrane. So these are what we call as the integral proteins. Now if you ask me one more question, that what is the structure of the spectrin? and what are the things that spectrin is going to do. And you can see spectrin is divided into basically three things. One is the body of the spectrin. I can write in a different color, maybe in pink. This is the body of the spectrin, and if you see, this is the tail of the spectrin, and this is the head of the spectrin. Clear? So near the body of the spectrin, they are wound together, which means they are like knitting together, and they are actually separating out. Apart from the body, when they're moving towards the head and the tail, they tend to separate out, and towards the tail, typically they reassociate with each other, which means all the four spectrin tails are going to reassociate with each other, which means at the tail end they are going to form something called tetramers. This is a very important MCQ in the exam. Tetramers of spectrin are formed in the tail of the spectrin molecule. So where they form the tails with the help of association with the actin molecule, the interaction is increased by this band 4.1 protein. That's what is going to happen. This protein 4.1 is going to increase the interaction between spectrin and the actin. So this is just an enhancer. And if you see at the head, of the molecule, at the head, if you see, this spectrin is associated with a molecule called ankyrin. Ankyrin is going to be associated with spectrin at the head end of the molecule, and again this interaction is increased by this band 4.2, that is called protein 4.2 or pallidin molecule. So this is the basic structure of the RBC membrane. This is very important understanding, because in the future when you are discussing about hereditary spherocytosis, I will be taking ankyrin defect and spectrin defect. Without understanding any of this, it's very difficult to know what I'm talking about in the future. So the basic defects of ankyrin or spectrin, or even band 4.3 proteins and all these things, defects, can result in different shape of the RBCs, like hereditary spherocytosis and hereditary elliptocytosis. For example, if somebody asks you the most common mutation in hereditary spherocytosis, it is the ankyrin defect. That is the usual commonest thing that is happening in hereditary spherocytosis, and spectrin defects typically happens in hereditary elliptocytosis. But anyway, these are the RBC cytoskeletal and membrane defects that is going to result in different shapes of the RBC. So this thing you have to know, that is the RBC structure, membrane structure. Once you have known about the RBC membrane structure, the next thing to understand is on the heme synthesis. So before going on to the proper heme synthesis, we can talk about how the RBC is, RBC content is, what is the content of the RBC cytoplasm. So if you ask me about the content of the RBC cytoplasm, the first thing you know very well, you have heme, and this heme is going to come from two important components. One is called the iron, and second is the protoporphyrin. This heme and protoporphyrin is going, this heme is going to mix with the globin with the synthesis from the ribosomes, and they are going to form something called a hemoglobin. So you know very well, this hemoglobin is going to be functional till the mature RBC is functional. So once the RBC becomes senescent, and they are tagged by a lot of senescent proteins once they age up, which means what is the lifespan of the RBCs? Approximately 90 to 120 days. After this, the RBC will become senescent. Once they become senescent, they will be swallowed up by the splenic macrophage. They will be identified by the attachment of the senescent proteins, and the splenic macrophages are going to swallow them. Once they swallow the once they are swallowed by the splenic macrophages, they are going to completely dissect the RBCs, and they are going to destroy the RBC, and once again you are going to release heme as well as globin, and again this globin is going to be further dissected into amino acids, further broken down into amino acids, which can be reutilized and recycled for further needs, further maybe other DNA events or other protein events happening in the body. The heme can be further broken down to something called a biliverdin by an enzyme called heme oxygenase. In this process, you release carbon monoxide. Why I told you this point very importantly is because this is the only endogenous source of carbon monoxide in the body. You don't have any other endogenous source of carbon monoxide production. This is the only source. That's why this is also a question in the exam. So you have heme oxygenase which produces biliverdin. This biliverdin is further converted to something called a bilirubin, which is done by an enzyme called biliverdin reductase. And both these steps need NADPH as a cofactor. You need NADPH at both these steps. And bilirubin is further, taken down in the liver and the enterohepatic circulation. It enters the liver and it also enters something called enterohepatic circulation, the details of which is clearly discussed in the hepatology part. So which I have discussed about the bilirubin, we have clearly dissected the entire thing about how bilirubin works and bilirubin is synthesized and how it is handled, bilirubin handling by the liver, and all these things we have discussed in the hepatology section. So we are not going to discuss right now. So this is what is going to happen. So it's the reverse of the formation process that is happening in the destruction process as well. So in this compound, you can see we are going to discuss about the globin chain production in the next section. But before that, let us see about the heme production, and let us see about the heme production here. And there are two essential components for heme production, that is iron and protoporphyrin. In particular, we are going to discuss about the protoporphyrin synthesis right now, because protoporphyrin ring is very, very important for the formation of heme. Iron we know, we are going to discuss a lot of iron deficiency anemia and anemia of chronic disease and all, but in general, first we will discuss of the protoporphyrin synthesis in this particular section. So how this heme synthesis and protoporphyrin synthesis is going to happen. So this is the basic idea about the heme and protoporphyrin synthesis. The first thing you can see, this glycine and succinyl-CoA is uniting to form something called a delta ALA, that is called aminolevulinic acid or delta aminolevulinic acid. This delta aminolevulinic acid is a very, very important compound, because in many of the hepatic pathways, this is the one that is going to increase in levels, and this is the one that is result in something called a neurovisceral complication in porphyrias. So that is why this delta ALA is a very, very important compound. Number one. This delta ALA, you can see it's going to enter the cytosol, because you can see the porphyrin synthesis starts in the mitochondria, it continues in the cytosol, and again it ends in the mitochondria. Finally, it ends in the mitochondria as well. So it starts in the mitochondria, continues in the cytosol, and finally ends in the mitochondria. So all this this process takes place in both cytosol as well as the mitochondria, which is again very important. So once this delta ALA comes, it's going to form porphobilinogen, this is going to form HMB hydroxymethylbilin, this is going to form uroporphyrogen 3, which I can simply write as Uro 3, and this can form coproporphyrogen 3, others called as copro 3, which again re-enters the mitochondria and forms protoporphyrogen, which forms protoporphyrin, and finally it forms heme with the addition of iron to it. So this is how it ends. So at every single step, you can get a enzyme deficiency and you can have a porphyria. But exception where you don't have the porphyria, generally this ALA synthase deficiency, generally we don't put under porphyrias, the reason being because they are going to produce only anemia, nothing else. Anemia only will be there won't be any photosensitivity, there won't be any neurovessel complication. Only, in this condition, the ALA levels will be reduced in amount. So that is what we refer to as X-linked congenital sideroblastic anemia, if you have a congenital ALA synthase deficiency. But ALA synthase deficiency can also be acquired, because it's a functional deficiency of ALA synthase, because ALA synthase, this vitamin B6, that is pyridoxine, is a cofactor. So in a pyridoxine deficiency, you might result in a picture similar to that of ALA synthase deficiency. That's what we call it as a sideroblastic anemia. Once again, so only this we are not going to talk in porphyrias, because this is not a part of porphyria, but other enzyme deficiencies typically is going to result in a porphyria. For example, if you have a ALA dehydratase deficiency, this is what we refer to as something called a DOS porphyria. DOS porphyria can be congenital or it can be acquired, and one of the important things that cause acquired DOS porphyria is lead poisoning. And you can see two areas the lead poisoning is going to affect. I can write lead poisoning here, and again lead poisoning is also going to denature the ferrochelatase enzyme, and it's also going to denature the ALA dehydratase enzyme also. Why typically the lead affects the ferrochelatase and ALA dehydratase enzyme? The reason is very, very quite simple. This step, this ALA dehydratase, even though it's not mentioned, you need one important compound called zinc. It's a cofactor for this ALA dehydratase enzyme. Similarly, this iron is a very important compound in this step for this ferrochelatase enzyme. So if you ask me one thing that is common between iron and zinc, you can see that both are divalent cations. At the same time, this lead is also divalent cation, this plumbum, that Pb2+, lead is also divalent cation. which means they can replace the iron in the ferrochelatase enzyme and they can replace the zinc in the ALA dehydratase enzyme, and they can completely replace them and they can reduce the function of these two enzymes, resulting in a poor production of heme and resulting in a porphyria like picture, and it can result in a different sideroblastic anemia as well. So that is why lead poisoning is very important to understand. At the same time, whenever you think about porphyrias, you can classify porphyrias. How will you classify porphyrias? I will come back to that image in some time. How will you classify porphyrias is based on whether they are hepatic or whether they are erythropoietic. The moment I tell porphyrias, I can tell whether it's a hepatic porphyria or it's going to be a erythropoietic porphyria. Erythropoietic porphyria. Under erythropoietic porphyria, you have only two porphyrias. The first one, you have something called congenital erythropoietic porphyria. Otherwise, simply I can call it as CPP, or you have something called erythropoietic protoporphyria. Erythropoietic protoporphyria, or simply I can write it as EPP. This is erythropoietic protoporphyria. So how can I differentiate between them? Because both this definitely will produce photosensitivity. There is no doubt about that. Both these porphyrias will have photosensitivity, but this congenital erythropoietic protoporphyria is the one that is going to have additional hemolysis. Photosensitivity along with additional significant hemolysis you will get only in congenital erythropoietic porphyria. So only in this condition you are going to get additional significant hemolysis. And when you think about this hepatic porphyrias you can classify into two. One is patients with neurovisceral complications, predominant neurovisceral features. What do you mean by neurovisceral features? Visceral, you know very well, visceral means it is abdominal pain. That's what I am talking about, visceral pain. And if you talk about neuro features which means they are going to have something called neuropsychiatric features. Neuropsychiatric features, it can range from the neuropsychiatric features means typically they will produce a peripheral neuropathy, and the peripheral neuropathy severity can vary from a simple wrist drop to even a complicated quadriparesis with respiratory failure also. It can result in any amount of severity. And psychiatric problems means they can result from simple depression to complicated, like maniac psychosis also. All these things are possible in these neurovisceral features. Or these patients predominantly come with photosensitivity only, or they can come with photosensitivity only without any neurovisceral features. What are the classic examples? The moment I tell a hepatic porphyria, I didn't tell you this definition. If you ask about what is hepatic porphyria, the enzyme deficiency happens in the liver. If you ask me about what is a erythropoietic porphyria, which means the enzyme deficiency happens in the RBCs. That's all. Enzyme deficiency happens in the RBCs, we call it as erythropoietic porphyrias. Enzyme deficiency happening in the liver is what we call it as hepatic porphyrias. So photosensitivity only without neurovisceral features means only one diagnosis possible, that is a porphyria cutanea tarda, PCT. Generally, porphyria cutanea tarda is due to deficiency of an important enzyme. So you can see porphyria cutanea tarda, if I put, it is due to deficiency of an important enzyme that is called UROD, uroporphinogen decarboxylase. So the moment I ask about uroporphinogen decarboxylase, there are two types of UROD deficiency. Suppose if I tell it's a UROD deficiency, usually this mild to moderate forms of deficiency typically results in a PCT, that is porphyria cutanea tarda. If it's a severe deficiency, severe UROD deficiency, it will result in a different type of porphyria, that is nothing but you can imagine like a severe form of a PCT, that is called hepatoerythropoietic porphyria, that's called HEP. In severe, absolutely absent, completely absent enzyme or very, very severe deficiency results in a severe disease, which means it's like a PCT augmented. It's an augmented form of a PCT, very severe form of PCT. You can remember as it's a hepatoerythropoietic porphyria. Porphyria cutanea tarda is generally autosomal dominant in nature, whereas hepatoerythropoietic porphyria is autosomal recessive, which means both the genes are inactivated. That's what it means. It is inherited as an autosomal recessive trait. And PCT, if you ask me, typically it presents like what? Chronic, and hepatoerythropoietic porphyria also is going to present like a chronic form only. There is no doubt about that. So these are chronic porphyrias. And what are the porphyrias that come with neurovisceral complications? If you ask me about the porphyrias that come with neurovisceral complications, again I can divide into porphyrias without photosensitivity and hepatic porphyrias with neurovascular complications with photosensitivity. Without photosensitivity, only two porphyrias are there. One is called acute intermittent porphyria and second one is the DOS porphyria. They don't have photosensitivity. If you ask me where is the acute intermittent porphyria and DOS porphyria in this, if you have a ALA D-reduced deficiency, you are going to result in a DOS porphyria. And if you have a PBG deaminase, porphobilinogen, you can simply write as PBGD, porphobilinogen deaminase, and certain biochemistry textbooks will give us HMB synthase enzyme also. In deficiency of this enzyme will result in a acute intermittent porphyria, which is the second most common porphyria in the world, which we are going to discuss in the subsequent topics. So these are two things that are going to have a neurovisceral complications, but without photosensitivity. If you ask me neurovisceral with photosensitivity, then there are two porphyrias, that is hepatoerythropoietic porphyria, that is hereditary copperoporphyria, and the second one you have something called a variegate porphyria. These are the two porphyrias that are going to present with neurovisceral complications, but at the same time they also have photosensitivity. Very simple. So which means from here to here, if I classify these four porphyrias, that is AIP, DOS porphyria, hereditary copperoporphyria and variegate porphyria, are going to have neurovisceral complications. And these porphyrias, hepatoerythropoietic porphyria, porphyria cutanea tarda, congenital erythropoietic porphyria, erythropoietic protoporphyria, are going to have photosensitivity only without neurovisceral complications. These are the four porphyrias that are going to have no neurovisceral complications. How will you easily understand that what are the erythropoietic porphyrias? I can write these two. I can put like this erythropoietic protoporphyria. That's why I put the diagram in this form. And if you have this congenital erythropoietic porphyria, side to side if you see, they are not going to have any neurovisceral complications, which means if side to side if I write like this green, these are the erythropoietic porphyrias. And what are the hepatic porphyrias? Remaining everything is hepatic porphyria only. But what are the hepatic porphyrias that come with neurovisceral complications? Very simple again. You can put side by side this lead poisoning and ALA D-reduced deficiency, that is DOS porphyria, acute intermittent porphyria, hereditary copperoporphyria, and variegate porphyria. All these four things which I can put in red boxes. So these all are going to present with neurovisceral complications. For sure. And in this, which are the things that are going to come with neurovisceral complications only without photosensitivity? You can split into two. Those enzyme deficiencies that are happening in the cytosol will have neurovisceral only. Those that are happening in the mitochondria, those enzyme deficiencies that are happening in the mitochondria will have photosensitivity with neurovisceral complications. Which means they are going to have photosensitivity. So that's it. So these are some clues or some mnemonic like things that you can make out from the porphyria, like enzyme pathway itself. And finally, if you ask about the porphyria cutanea tarda, this is going to be a hepatic porphyria only, but there is no neurovisceral complication and the patient is going to have photosensitivity only. And this is how you are going to divide. As simple as that. And what are the acute porphyrias and what are the chronic porphyrias? And acute porphyrias, if you ask me, acute porphyrias are the ones this is one way of dividing them. Similarly, I can tell acute porphyrias as well as chronic porphyrias. Acute porphyrias, again, these four are the acute porphyrias. The things that I have marked in red are the ones that are going to be acute porphyrias, which means it's going to be acute intermittent porphyria, it's going to be DOS porphyria, it's going to be hereditary copperoporphyria, and it's going to be variegate porphyria, which means in that initial thing, which all I have marked in red are going to be acute porphyrias. And chronic porphyrias, typically they come with, there are four porphyrias. For example, you have a PCT and its severe form, that is hepatoerythropoietic porphyria. Then you have with the congenital erythropoietic porphyria, and you have a erythropoietic protoporphyria. In all these conditions, you are going to have a chronic form of porphyria. Again, this is very important. And next thing what they will ask is what are the autosomal dominant and what are the autosomal recessive conditions. It's very easy to understand again. Autosomal dominant, all the acute porphyrias tend to be something called autosomal dominant in nature. So all the acute porphyrias, for example, acute myeloid porphyria, then you have DOS porphyria, then you have hereditary copperoporphyria, then you have variegate porphyria. All these things tend to be autosomal dominant. But one additional thing that tends to be autosomal dominant is the Porphyria cutanea tarda. This also tends to be autosomal dominant in nature, which means all the acute porphyrias tend to be autosomal dominant. This is a mnemonic with one addition, that is Porphyria cutanea tarda. So that also tends to be autosomal dominant only. Remaining everything, now you have hepatoerythropoietic porphyria, then congenital erythropoietic porphyria, then erythropoietic protoporphyria. In all these conditions, they tend to be something called autosomal recessive in inheritance. I told you ALA synthase deficiency is typically X-linked recessive, which means it's an X-linked disease. That's why it's called X-linked sideroblastic anemia. We are not going to discuss under porphyrias in the first place, but this is how the mnemonics, acute porphyrias with the addition of Porphyria cutanea tarda are autosomal dominant in inheritance. All the chronic porphyrias which I have told you, with the exception of PCT, remaining all the chronic porphyrias are autosomal recessive in inheritance. So this is how you remember all these things. And how these acute porphyrias typically present? Acute porphyrias are going to typically present with neurovisceral, predominantly a neurovisceral feature. And chronic porphyrias typically are going to present with blistering skin lesions. Blistering skin lesions. But there is again one exception for this blistering skin lesions, which means all are going to come present predominantly with photosensitivity only. But you know very well, one exception for this blistering skin lesion is there, that is erythropoietic protoporphyria, which means in erythropoietic protoporphyria, what is the exception which I am mentioning? They tend to be non-blistering. They tend to be non-blistering in nature. Very, very, very important point. Because if they ask about, see, the congenital erythropoietic, PCT is a chronic blistering lesion and hepatoerythropoietic porphyria is also chronic blistering lesion. What they're going to ask is, this also is not going to have any neurovisceral complication. How will you differentiate each and everything? For example, this CEP can be easily differentiated, congenital erythropoietic porphyria can be easily differentiated because they are going to have additional significant hemolysis, which means PCT, HEP, that hepatoerythropoietic porphyria, and EPP, erythropoietic protoporphyria, is not going to have hemolysis. But how will you differentiate this PCT itself from EPP, erythropoietic protoporphyria? Is by the fact that this erythropoietic protoporphyria is non-blistering and this PCT and hepatoerythropoietic porphyria are blistering skin lesions in nature. So that's a very important point. Erythropoietic protoporphyria is non-blistering. So now you know very well what is hepatic, what is erythropoietic, and what do you mean by acute, what do you mean by chronic, what are the phases of acute, what are the phases of chronic, and what are the autosomal dominant porphyrias and what are the autosomal recessive porphyrias, and what is the X-linked sideroblastic anemia. All these things we are very, very thorough with right now. Apart from that, one important thing you have to understand is, since the enzyme deficiency happens in the liver, okay, not in the RBC, since the enzyme deficiency, because iron is important, this heme, not only iron, this iron and heme are important for formation of cytochrome enzymes in the liver also. That is why liver is also going to suffer from this porphyrin synthesis defects. Liver is also going to suffer because of the poor production of the cytochrome enzymes. So what is going to happen is, to produce heme, I told you, you need a porphyrin and you need iron. And this heme is the one that is going to be incorporated, for example, cytochrome enzymes, hemoglobin, all these things, myoglobin, all these things to produce this iron. Heme is the one that is going to be incorporated. In this porphyrias, the problem is there is very, very poor porphyrin synthesis, protoporphyrin synthesis, which means that is going to reduce heme synthesis, and that is not our point of concern right now. Our point of concern is this is going to increase the free and underutilization of iron. Free iron, as well as, that is because of the underutilization of the iron, your free iron is going to increase. Suppose if this excessive iron is happening in the liver, it's going to result in something called hepatic iron overload, which is going to result in something called a hepatic iron overload. So once you are going to get something called an hepatic iron overload, this per se is going to increase the risk of hepatocellular cancer and cirrhosis. Cirrhosis and hepatocellular cancer is very high, which means all the hepatic porphyrias are going to have high risk of hepatic iron overload, cirrhosis and hepatocellular cancer. So HCC risk is very high with most of the hepatic porphyrias. Erythropoietic porphyrias has very little risk is there, but all the hepatic porphyrias, including porphyria cutanea tarda, even though they produce only skin lesions, still they have a very high risk of producing liver cirrhosis and hepatocellular cancer and hepatic iron overload. Very important point, all these things. So these are the general overview of the porphyrias in general. But next thing, what we have to see is one of the two important porphyrias that are important for exam is, one is the PCT, that is the porphyria cutanea tarda, and second one is your acute independent porphyria. PCT is supposed to be the most common porphyria in the world. Most common porphyria in the world, if they ask you, answer is PCT. It is autosomal dominant, but its severe form I told you, that is hepatoerythropoietic porphyria, that could be autosomal recessive. The reason pathophysiology, if somebody asks it is due to something called that Euro D deficiency, that is called uroporphyrinogen 3 decarboxylase deficiency. That is the reason for developing a PCT. Severe, typically in the mild to moderate forms. Mild to moderate deficiency. If it's a severe deficiency, it will result in another phenotype that is autosomal recessive in nature, that is called hepatoerythropoietic protoporphyria, and typically it is very common in males. We don't know why, even though it's autosomal dominant, it should be equal in distribution, but typically it's quite common in males compared to that of the females, and usually it happens around 40 to 70 years, in the age group of 40 to 70 years. And again, PCT can be two types are there. Type 1, if they ask you what is type 1 PCT, that is an acquired deficiency of UroD. Acquired deficiency can happen in liver diseases. Like for example, hepatic cirrhosis, liver cirrhosis, in these conditions you might have acquired deficiency, or if chronic alcohol intake can result in acquired deficiencies. Type 2. Type 2 is typically congenital deficiency. There is no need of explanation for that. It's a congenital deficiency of urodecarboxylase enzyme. So what are the risk factors for getting a PCT? What are the risk factors? Either you can have low enzyme levels. The risk factors for getting low enzyme levels is liver disease, number 1. Liver disease. Typically, best example in exam, what they will ask you is in iron overload. In iron overload state. And a typical example of iron overload state in textbooks is hereditary hemochromatosis. That's why I told hereditary hemochromatosis. Typical example of an iron overload in exam. So liver disease. Second thing, alcohol can reduce the enzyme level. Apart from that, certain viruses like hepatitis C virus, HIV is also very important, and HIV also you can write, but HCV is the most important, because this PCT is one of the important extrahepatic manifestation of hepatitis C virus. Extrahepatic manifestation of hepatitis C virus. This PCT is one of the important extrahepatic manifestation of hepatitis C virus. I have discussed in detail about this in the HCV virus topic in the hepatology, but still right now you have to understand this is a very important extrahepatic manifestation of hepatitis C virus. You can imagine like HCV also causes liver disease, and that's why they cause that deficiency in the liver, which can result in a hepatic porphyria like PCT. Absolutely possible. You can write HIV also can cause at the same time. You can, one of the other risk factors is estrogen therapy, and the other risk factors is sunlight exposure, or otherwise you can call it as a UV light exposure. Sunlight and UV light exposure, all these things are some of the risk factors for developing a porphyria cutanea tarda, PCT. Apart from that, what will be the clinical findings? Typical clinical finding, what you're going to see is the chronic blistering skin lesions. So this chronic blistering skin lesions, why they do develop the blisters is because, what is the pathophysiology? If you ask me, your uroporphyrinogen 3 is going to be converted to coproporphyrinogen 3, and this is where the enzyme, this urodecarboxylase, comes into play. If this enzyme is not there, your uro 3 levels is going to be very high. So which means your porphyrin level circulating will be very high. These porphyrins are very having high affinity for the skin, so they can deposit in the skin, especially at the dermoepidermal junction. So when they deposit in the dermoepidermal junction, at the same time when they are exposed to the ultraviolet light, when they are exposed to the sunlight, because these compounds are actually highly photosensitive. These porphyrins are highly photosensitive, and when the UV light touches this dermoepidermal junction, you are going to result in a release of energy. For example, these compounds, it means photosensitive means they absorb energy, absorb light. At the same time, after absorbing light, the electrons will be shifted to the higher orbital. When they come back to the lower orbital, they're going to lose energy again. They're going to release energy in the form of light or photons or something. So they're going to release energy by absorbing sunlight. That will cause energy related damage in the dermoepidermal junction, which will result in splitting of the dermoepidermal junction, causing tense blisters. Tense blisters, which means they are going to form subepidermal blisters, and the split at the dermoepidermal junction. Once you split, there will be fluid accumulation, oozing out, and edema, resulting in a formation of a blister, and that's how we are going to get a tense blister with these things. So at the same time, since they deposit at this region, they also result in impaired healing and scarring. They can also result in impaired healing. Because of that, they can result in scarring as well as melia formation. All these things are absolutely possible. And where you develop all these changes, you can see this image, to be honest, if you see where you develop all these changes, very classically common in the dorsum of the hand. Typically in the sun exposed areas, very commonly common area that is exposed to the sun is the dorsum of the hand. Plus you can get in the face, you can get in the neck, and you can get in the extensor surface of the limbs. Extensor surface are the ones that are commonly sun exposed. This is the extensor surface, very commonly sun exposed. Leg, the extensor surface is the one that is commonly sun exposed. So the very commonly you can see in the sun exposed areas. You can see here there is an intact blister here, which means intact blister itself means it's a tense blister, and you can see a lot of partially healed lesions, and this man with a lot of scars in the dorsum of the hand, you can see again. At the same time, these patients also tend to go for hyperpigmentation, and again this is evident in this image. Lot of hyperpigmented areas are there. Plus they can even go for hypertrichosis, and this is common in the face. Hypertrichosis is common in the affected areas in the face, and again patients may look like full of hairy in the face, and all these things are possible in this thing. And this is the urine of the patient during an acute exacerbation. They can have something called a tea-colored urine. This can happen in any porphyria, not only in porphyria cutanea tarda. This can even happen in a acute intermittent porphyria also. That is because of the oxidation of the porphyrin compounds when they are exposed to light in the outside, when the urine is passed. So this is the control. This is a control urine, clear urine. You can see the tea-colored urine in porphyria. This can happen in acute exacerbation of a chronic acute intermittent porphyria. Acute exacerbation of a chronic PCT, or it can be seen in acute intermittent porphyria as well. This is not specific finding. Anyways, this is a tea-colored urine in these patients. And the next thing what you can see is in this porphyria, what are the investigations you will do? Typically, you have to screen for the urine porphyrin levels. I'm going to typically see the uroporphyrin levels. More than porphyrin, I'm going to see the urinary uroporphyrin levels, which will be elevated in this patient, obviously. At the same time, this patient also may show tea-colored urine. I told you already, that is because the excess porphyrins discoloring the urine. So tea-colored urine is possible. And if you put this tea-colored urine in Wood's lamp, suppose if you put this urine in Wood's lamp, they will show something called a coral pink fluorescence. Very important point for exam. And again, you are going to develop something called a coral pink fluorescence, which is again typically very, very important. So this is what is going to happen in the Wood's lamp when you put this urine. Treatment wise, if you ask me what is the treatment you do, first is the avoidance of triggers. Avoid triggers that cause porphyria like alcohol, estrogen therapy, avoid excessive sunlight exposure. All these things are very important. They have to use sunscreens very strictly. Plus or minus, you can use phlebotomy, because phlebotomy is to remove the iron from the body in patients who are having iron overload features. So in these patients who are having hepatic iron overload, hepatic iron overload can be assessed with MRI itself. One of the best non-invasive investigations to assess the hepatic iron overload is the MRI. Invasively, liver biopsy can do, but non-invasively you can do by MRI itself. MRI showing features of hepatic iron overload, then you can do phlebotomies also to remove the iron from the body. Remember, the only way to remove iron from an adult patient who's not having any menstrual cycles is phlebotomy only, or you have to give iron chelators. Some way you have to find. Here there is no need for iron chelators. You have to do only phlebotomy. And plus or minus, you can add hydroxychloroquine or a chloroquine. How this hydroxychloroquine or chloroquine works, because how this is going to work is by forming a water soluble complex with porphyrin compounds, because chloroquine and quinine related derivatives have high affinity towards the porphyrin compounds. Once you give chloroquine or hydroxychloroquine, they're going to bind with this porphyrin compounds and they're going to become more water soluble and they're excreted in the urine very faster, which results in prevention of accumulation of this porphyrin based compound. That is the mechanism of action of hydroxychloroquine and chloroquine in PCD. So these are the different features you're going to see. So next we are going to see the next porphyria, that is acute intermittent porphyria, otherwise simply you can call it as AIP, that is acute intermittent porphyria. So when you want to know about acute intermittent porphyria, the first point I want to tell is the second most common porphyria in the world. So this is going to be the second most common porphyria in the world. So typical, it is again autosomal dominant in nature. It's an acute porphyria, definitely it will be autosomal dominant. And if you ask me the age group, it is in the 30s usually, whereas that is in the 40s and 50s. Porphyria cutanea tarda. Porphyria cutanea tarda is more common in males, even though it is autosomal dominant, but this is common in females predominantly. We don't know why. And typically in the 30s. Clear? So this is where you are going to see acute intermittent porphyria. So what is the reason for acute intermittent porphyria? If you ask me the pathophysiology, you see something called succinyl-CoA plus glycine under the influence of your enzyme called ALA synthase is going to result in formation of delta amino levulinic acid. So this delta amino levulinic acid under the influence of something called ALA dehydradase enzyme, it's going to result in something called a porphobilinogen. We all know that. Porphobilinogen. This porphobilinogen, with the help of something called a PBG deaminase, it's called porphobilinogen deaminase, it's going to form something called hydroxymethyl bilane. That's why this PBG deaminase is also called as HMB synthase, other name for this enzyme. So they are going to form hydroxymethyl bilane. The enzyme defect of acute intermittent porphyria is the PBG deaminase only. This is the place where you get acute intermittent porphyria. I told you already, which means they are going to increase the porphobilinogen levels. At the same time, they are going to increase the delta ALA levels. This increased delta ALA levels is thought to be the reason for neurovisceral complications. Since actually this hydroxymethyl bilane is the one that is going to form porphyrin based compounds. Your porphobilinogen cannot form porphyrin based compounds. This porphobilinogen, which means it cannot form any porphyrin based compounds. That is the reason this is one of the crucial things to understand, that there is no photosensitivity in case of acute intermittent porphyria. There is no photosensitivity because till porphobilinogen, this porphobilinogen cannot be transformed into any of the cyclical porphyrins. Impossible. From only HMB, you can form cyclical porphyrins. That is the reason why beyond this only you can get photosensitivity. Before this, it's impossible to develop photosensitivity. That is the reason why ALA dehydradase deficiency as well as ALA PBG deaminase deficiency are not going to develop any photosensitivity. You are going to develop only neuropsychiatric, neurovisceral management like abdominal pain and neuropsychiatric complications. That's all. So that is the reason this is one of the few porphyrias. Very important clinical features if they ask you. Very important, patient is going to have neurovisceral problems, which I mentioned already, like neuropsychiatric problems and abdominal pain, but no photosensitivity. But no photosensitivity. Very, very, very important point. No photosensitivity. And it can result in autonomic neuropathy also. They can result in palpitations, tachycardia, and bladder bowel incontinence. All these things are possible, but not photosensitivity. Definitely no photosensitivity. Whereas PCT comes only with photosensitivity without any neurovisceral problems, whereas this one comes only with neurovisceral problems without any photosensitivity in the first place. So, how will you establish a diagnosis of this porphyrias? The diagnosis of this acute intermittent porphyria is typically established by checking for the urine porphyrin levels. Urine porphyrin levels again. So, urine porphyrin levels are typically not elevated in case of acute intermittent porphyria. Usually it will be normal. So what will be elevated then? Urine levels of porphobilinogen, PBG, will be elevated. At the same time, urine levels of ALA also will be elevated. This will definitely clinch the diagnosis. And remember, this increased ALA levels is not specific for acute intermittent porphyria, because this increased ALA levels can be seen in lead poisoning itself. Lead poisoning itself. Why in lead poisoning? Because if you see this diagram which I have drawn, lead poisoning affects the ALA dehydradase enzyme, which still can increase the ALA level. So ALA levels is not specific for acute porphyria, but still this porphobilinogen level increase may be relatively specific for acute porphyria. At the same time, this PBG is actually colorless. For example, if you ask me, this PBG is actually, because this is an important concept to understand, this PBG typically tends to be colorless. So which means you all expect the urine to be white, but urine also tends to be dark colored in this acute porphyria. The reason is this PBG can be degraded to porphobilin. And this porphobilin, yes, it does have a color, that is having a brownish color. That is the reason why even in an acute attack of AAP, even in acute AAP, the urine color may be brownish or something like a tea colored like this, possible. So even in an acute attack of a AAP, this is still possible. You can get a brownish urine, absolutely possible. That is because the PBG per se, you can ask me, PBG itself is colorless, but it can get oxidized to porphobilin. Because of that only, it is possible to have a brownish urine in a case of acute porphyria also, absolutely possible. So this is how you establish it and needs a very high degree of suspicion. And if you ask me about the risk factors for developing a PBG, this acute porphyria. So first thing you have to understand is this ALA synthase enzyme is the rate limiting step in the porphyrin synthesis. In the the porphyrin ring synthesis and heme synthesis, this ALA synthase enzyme is the rate limiting step. And there are a lot of, and remember this, I told you ALA synthase enzyme is mitochondrial enzyme also, which means it forms a cytochrome group as well. So which means it is susceptible to lot of enzyme inducers as well as enzyme inhibitors. It is susceptible to lot of enzyme inducers as well as enzyme inhibitors as well. That's why it's very important. And one more important thing that can feedbackly inhibit the rate limiting step, that is the ALA synthase enzyme, is because once you form HMB, this HMB finally after a lot of steps it's going to form heme, and this heme itself is going to act as a negative regulator for the ALA synthase enzyme, because this is a feedback system and it's going to inhibit because the final product is heme, the final product itself will inhibit the rate limiting step. That's a very common thing in biochemistry we see. So for example, if the patient is having a PBG deficiency, PBG deaminase deficiency, and if you are giving some enzyme inducer, you are going to accelerate the activity of ALA synthase enzyme. What you are going to develop? You are going to produce increased ALA. At the same time, you are going to produce increased porphobilinogen, but this cannot progress beyond the block because already there is a reduced activity of PBG deaminase in acute porphyria. So these compounds tend to accumulate and they are going to precipitate an acute attack. That is why enzyme inducers of the ALA synthase enzyme form a very, very important trigger for the development of acute attack of an acute porphyria in patients who are having a PBG deaminase deficiency. At the same time, this heme, since it is acting as a negative feedback down regulator of ALA synthase, if you give artificial heme infusions of heme, if you give an artificial heme infusion, there is a lot of possibility you might reduce the formation of ALA and porphobilinogen, which means once you reduce the ALA itself, your neurovisceral complications might reduce. Very simple. So that is why I told you what are the triggers. At the same time, you can see the applied treatment aspect also from this particular image. And if you ask me what are the risk factors for developing this acute porphyria, come back to that. The lot of enzyme inducers are there. For example, especially drugs. Drugs wise, if you ask me, your anti-epileptic drugs like barbiturates, enzyme inducers, then your phenytoin is a very important enzyme inducer. Then you have something like carbamazepine, which is also an enzyme inducer. Then you have clonazepam, which is a benzodiazepine, very important drug. Clonazepam is such a commonly used drug because it's such a commonly used benzodiazepine in the routine day-to-day practice itself. So that can induce a porphyria attack. So anti-epileptic drugs, very important. At the same time, next thing you can get with lot of sulfonamides. Sulfa drugs can induce this enzyme. At the same time, you can alcohol. Alcohol is a very important microsomal enzyme inducer, isn't it? So alcohol can induce this enzyme. Smoking can precipitate an attack, especially sex hormones. especially progesterone containing pills. More than estrogen, the progesterone is very important. Similarly, fasting state. Fasting can increase the production of, accelerate the ALA synthase activity, and that is the reason why even fasting can precipitate an acute attack. At the same time, stress can increase the production of ALA synthase, like surgery, infection, all these things also can exacerbate the acute attack of AAP, precipitate an acute attack of acute intermittent porphyria. All these things are possible. In this, the most important is the barbiturates, phenytoin, clonazepam, alcohol, progesterone, and fasting. All these things are multiple times asked question in the exam. So very, very important risk factors. If you ask me the treatment, how will you treat this AAP? Again, avoidance of triggers is the key. You have to avoid the triggers as much as possible, which is a very important key for avoiding these attacks. And second thing, you can give some treatment. Typically, you are going to use IV fluids, hydrate the patient, plus you can give good calorie diet. Calories, like, which means you can give food and high calorie diet, so which can like glucose infusions, in the sense like food, or you can give glucose infusions, dextrose infusions. Because I told you fasting will accelerate the ALA synthase enzyme, but at the same time you are giving a good amount of glucose, which means which is opposite of the fasting, isn't it? So that can result in a reduced activity of ALA synthase. That is why we use these calories also. You can give artificial heme arginate infusions. It's available in the brand name heme arginate. Heme arginate infusions also you can try. By feedback, this heme should inhibit the ALA synthase enzyme. That's why it can lower the production of ALA and can alleviate the neurovisceral symptoms of porphyria. So all these things are very important points that you have to note about the porphyria. And even remember, AAP in long run also can result in hepatic iron overload, cirrhosis, and hepatocellular cancer. All these things are absolutely possible. With this, I think we have covered enough on porphyrias by this time. In the next section, we'll be discussing more on the globin synthesis and the hemoglobin production, and you can watch the next section for the globin synthesis for that. Cut.